Thank you very much, Rashtan. So Ame gave a talk on why, Rashtan also gave a talk on how to do it. I think we have another component of how, which actually what kind of local anesthetic solutions we should use and what infusion strategies we should actually employ in using a continuous PNB. Without further ado, I invite Dr. Beh to deliver his talk.
Good morning, everyone. Thank you for having me here. I'll be talking about the local anesthetic solution and infusion strategies. So I have nothing to disclose. All photography, videography shared in this presentation, I've obtained consent from my patient. So the content of my presentation consists of two parts: the choice of infusate, LA delivery regime, and infusion selection. Most of these points will be from the next slides, the source of my references. What I want to focus here is also to share with you what are the latest current continuous peripheral nerve block regime used in the common site-specific surgery, as well as those painful conditions. As shown in this slide, these are new several published, established articles, as well as the chapters in the textbook that pertaining to the continuous peripheral nerve blocks. But as you can see here, most of these publications are in 2017, and the latest is by Professor Mariano in 2019 in Astra website. There are newer developments in continuous peripheral nerve block, especially for the interfacial regional technique like ESP, and there are some groups are begin using the continuous peripheral nerve block technique. So this is a chance for me to share the update. Well, although continuous peripheral nerve block has been around for almost 2 decades, but actually the optimal infusion regimen for peripheral neural infusions remains unknown, whether it is the type of infusate, concentration, or duration of analgesia. For actually, all of us know that there are various factors that will affect the performance or efficacy of the perineural infusion, as highlighted by Dr. Rashtan. As such, that the nerve type of nerve localization technique, location, whether it's an upper or lower extremity block, even whether it's a proximal or distal nerve block, as well as the catheter type and the position of the catheter tip to the nerve bundles, it will affect the outcome of the perineural infusion. And more important, there's also the post-op pain intensity, which is very much influenced by the patient factor as well as the type of surgeries. As mentioned, so far till date, there is no optimal concentration rate combination that may be recommended for all anatomic location. But we commonly use long-acting local anesthetic as an infusate, which is either ropivacaine, bupivacaine, or levobupivacaine. Because this is for post-op analgesia, usually the LA that we use are low concentration. This is in order to minimize the muscle weakness during the infusion, as to facilitate rehabilitation, mobilization. Commonly described concentrations are ropivacaine 0.1 to 0.4%, bupivacaine 0.125% to 0.15%, and lower bupivacaine 0.1% to 0.125%. As referred to Professor Ilfeld's update of evidence of the continuous peripheral nerve block in 2017, there is minimal new information to help guide clinical practice. Data suggests that ropivacaine, bupivacaine, levobupivacaine provide similar analgesia, with the main differences being ropivacaine shorter duration of action, presumed easier for titration, but at the expense of the cost. So based on this small bracket here, what is an ideal LA infusion? It's definitely something that can provide analgesia, yet we minimize any sensory, motor, and proprioception deficit. And of course, the drug should have a favorable safety profile or toxic profile. Of course, it should be cheaper or cost efficacious. And when we off the infusion, usually sensory motor block should resolve quickly and predictably. And all these are suggestive of ropivacaine as the choice, the first choice. But we have to bear in mind again, among all these 3 drugs, ropivacaine is still the most expensive. For instance, in Malaysia, in my previous institution that I in University Malaysia, we had to pay for 28 ringgit for the ropivacaine, 0.75%, 20 ml vial. Compared to bupivacaine, 0.5%, 20 ml is only 8 ringgit. Nisora tips. An infusion with ropi 0.1 to 0.2% easier to titrate due to faster resolution of insensitive extremity. But bupivacaine 0.1% to 0.125% provides similar degree of analgesia and costs less in most regions and hospitals. Perineural infusion indeed exerts a varying degree of analgesia and motor block at different anatomic sites. And this interaction is real, between LA concentration and volume is really complex. For example, if you look at these three studies, and these three studies are done by the same group of investigators, which is Professor Brian Ufel, published at different journals, and they are using a similar LA regime to compare. Ropivacaine 0.2%, basal 8 ml per hour, bolus 4 ml, versus ropivacaine 0.4%, basal 4 ml per hour, bolus 2 ml. And mind you, all these total LA dose are the same. And from these three studies, it seems like if you are doing the lower limb blocks, a relatively concentrated solution in smaller volume is preferable because analgesia satisfaction are the same, but insensate limb are more in those larger volume, relatively dilute ropivacaine group. But if you do this for upper limb blocks, infraclavicular interscaling, a lower concentration of LA at higher basal rate seems to provide a better analgesia. So I move on to another concept here. Another important point is that total dose of LA is actually the primary determinant of clinical effects. So LA concentration and volume do not influence block characteristics as long as the total dose remains constant. And this has been found in numerous studies involving interscaling, femoral, lumbar plexus, and polyteal sciatic nerve block. However, other blocks like brachial plexus, adductor canal, TAP block remains unknown. But from this, take example for interscaling. If you use a ropivacaine 0.1% versus 0.2%, same basal 5 ml per hour, bolus 3 ml. Both groups have the same pin score motor block. Femoral nerve block, ropivacaine 0.1%, basal 12 ml per hour, bolus 4 ml versus 0.4% basal 3 ml per hour, bolus 1 ml. They have the same block characteristic. Likewise for the polyteal sciatic nerve blocks as well. And from these lower limb blocks that as shown in these studies, we can infer that actually can suggest that lowering the infusion rate for lower limb continuous nerve block with the concurrent increase in concentration will not compromise analgesia. In fact, it is an effective strategy in lowering the infusion rate per hour because eventually the LA consumption will be much lower. So we don't have to change the medication or backstow often. So there is an economic benefits. As well as there is because lesser changes, there's also reduced risk of infectious complications because of contamination. What are the infusics used for the continuous peripheral nerve block? Local anesthetic only. Although in the single short peripheral nerve block, there are a lot of studies trying to use adjuvants like dexamethasone, buprenorphine, Presidex, is to prolong the analgesia. But so far, the recommendation is that no adjuvants at this moment. There are sporadic RCTs reporting the benefits of various opioids in a perineural infusion. There are actually 5 studies, but most of these studies are lack of an active systemic control group. By adding opioids into that perineural infusion, there is also increased incidence of opioid-related side effects. That means for infusate for continuous peripheral nerve block, local anesthetic is the only solution that we use. How is the LA delivered? Yes, we are using infusion pump with the basal infusion bolus and combination of 2 modalities. And usually this regime will be reported as basal rate, bolus volume, and the bolus lockout time. The delivery of this regimen, the aim is to minimize the total LA consumption, reduce the supplemental opioid requirement, and of course, help in the daily functioning and minimize the sleep disturbance. And so far, I tell you, there's no single delivery regime that is ideal or optimal for all anatomic locations and clinical situations. In many cases, providing a basal infusion minimizes the breakthrough pain and supplementary need for the supplemental analgesic requirement. Whereas by adding the PCA bolus, it will definitely decrease the required basal infusion rate, incidence of the insensate extremity, and definitely eventually the LA consumption. In the case of ambulatory setting, of course, with a fixed amount of reservoir go home, we can provide a longer duration of infusion for the patient. What is our analgesic goals when we are trying to tailor an infusion strategy to a specific patient? Then this is a slide from Professor Philip Mackay. I thank him for this slide. For periplexus infusion, Our goal is to provide a functional analgesia. That means for pain at rest, usually we tackle it with laser infusion. For mobilization, we ask patients to use the PCA to press. The goal is to minimize numbness and hopefully avoid motor blockade to facilitate recovery rehab. But for interfacial pain infusion, which I will talk later in the site-specific group, the goal is different. We are trying to provide as extensive as possible the area of coverage for the surgery. So there is no issue with motor blockade or excessive numbness. So volume effect is the key, and that's why there's a now key term of the program, intermittent bolus, or even MIB stands for manually infused intermittent bolus, which can be done by our healthcare staff. The goal of all these infusion is make sure that whatever we deliver is within safety level. So we know that for epidural labor analgesia, the intermittent bolus strategy was first described, and current evidence shows that it's a high quality evidence show that intermittent epidural bolus is more superior in terms of lowering LA consumption and improved maternal satisfaction in comparison with continuous infusion in the obstetric cohort. So our colleagues, Dr. Jagannathan and the group, they are trying to analyze the current state of evidence for peripheral nerve block use, comparing intermittent bolus and continuous infusion. This is 13 RCTs included in these studies, and actually, I say from the conclusion of their study, their paper, it shows that PIB MIB technique for truncal peripheral nerve analgesia is effective, but cannot be currently recommended over continuous infusion strategies. But having said that, we have to bear in mind, actually perineural outcomes are likely anatomic site-specific, and studies varying LA delivery should be determined based on the type of blockade. This is a general overview in a table form of the published perineural infusion protocols for continuous peripheral nerve blocks using 0.2% propionate for various types of nerve block. And this is available in Astra website by Professor Marano. And just to bear in mind, these are just starting dose recommended. Adjustment may be necessary to maximize analgesia and minimize motor block for individual patients. But I will further discuss about the common LA regime strategy in pertinent to different sites of surgery in the later slide. Basically, what is the optimal duration of the perineural infusion? Till date, it has not been determined. Although there is the benefits of longer duration of infusion, but we have to bear in mind, by infusing more than 48 hours, the infection risk will also increase. So in our practice, we have to balance the infusion duration. We have to balance between the analgesic and functional benefits as well as the risk of infection. Of course, there are studies like by Professor Capdevila and group, and also Mayer and group. They show that sometimes they put the median infusion duration up to 2 to 7 days. For Mayer in the military, their subjects, they infuse up to 34 days, and the catheter-related side infection is only 1.9%, which actually resolved after catheter removal. For ambulatory basis for infusion duration, there is a lack of available evidence to formulate a guideline catheters, but we commonly use and remove the catheters after 2 to 3 days of infusion. The local anesthetic can be delivered via infusion pumps. As shown here, the infusion pumps that is used can be divided into electronic and non-electronic. Elastomeric is a non-electronic pump used usually for ambulatory. Of course, the best pump, the infusion pump, like there's the spacer as well as this micro. Micro is a newer version which is electronic, ambulatory, and actually is lightweight, small, portable, which is actually very good for suitable post-op patient that requires early mobilization. In fact, they also have some of this pump. They have a built-in remote monitoring, which I will share more on the site-specific surgery later. But basically, most of the time we put on the pump with the spacer, and this is one of the electronic pumps usually provide a very stable basal infusion rate over the course of the infusion if compared to elastomeric. the flow rate accuracy is up to 2 to 5%. Elastomeric about 15%. The elastomeric is good for ambulatory go home, for home pain management, discharge management, home infusion therapy. And because it's a disposable pump, it's actually lower cost. But mind you, in Malaysia, till date, the ambulatory perineural infusion, the service is still not well established. What about the cost? Yes, who are the players in this pump? You can see that for infusion, we have Braun, space infusion, then Agilia, then beneficial. For the other portable pump, we have the CAT and also Vicrel. Of course, you can see why I put here the price is really different. For the ambulatory elastomeric pump, the price range is about 200 ringgit to 1,200, depending on the what brand. For the infusion pump, stationary, it ranges from 8,000 to 12,000. But for this pump, it's actually much more, about 16,000. So now I will focus. I'll go on to the site-specific surgery and what are the continuous technique of choice. As mentioned by Dr. Ami, we know that interscalene brachial plexus block is the recommended first choice regional technique, gold standard. And interscalene brachial plexus block can be either given as a single shot or continuous infusion. But we also know that if we run an interscalene block over 24 hours in the infusion rate of 4 to 6 ml per hour, regardless of what concentration, patient would develop phrenic nerve palsy. In phrenic nerve palsy, in an individual, a young healthy patient, usually they are asymptomatic, they are all right. But in patients who are having the reserved FRC, and those who are obese patients, and those who have a respiratory problem, they may be symptomatic. So there is also a debate, a question of should continuous rather than single injection interscalene block be offered routinely for major shoulder surgery. So this is a meta-analysis by Dr. Faraj Abdallah from Canada. It was published in 2018. Even in this, there is a it is shared in Astra. But of course, from the meta-analysis, we know that continuous catheter usage will have a prolonged analgesic benefits up to 72 hours dynamic and resting pain. But from their reasoning is that in these studies, that in the meta-analysis, not many studies are high quality. Only 4 out of 50 are adequately blinded, and most studies are old. That means that older than 2013, and none of them are using the modern multimodal analgesia protocols like what we are doing today. And that's why it's still a debate. It all depends on the case. Take example, this is a study published in our surgeon site, orthopedic surgeons. Single shot versus interscalene continuous for post-op pain relief, shoulder arthroplasty, published last year, 2019. Actually, if you can look at the conclusion, for continuous interscalene block, opioid use and pain level is definitely lesser, but it did not shorten length of stay. The benefits of continuous interscalene block may not justify higher cost and complication rate. Just have a look. Single shot interscalene in US about $23 US, but when you use continuous technique, it jumps to 20 times. If phrenic nerve palsy is an issue, yes, we can use alternative technique, suitable technique like continuous supraclavicular brachial plexus block, as shown in this study by Professor Thorsten Steinfeld and his colleagues. And of course, the incidences of phrenic nerve palsy in the supraclavicular group is lesser. It's 24% versus 43%, and both groups has a similar pain score at rest and dynamic. So what are the infusion rate that is in these studies? They use a 4 ml per hour ropivacaine, 0.2%, 4 ml bolus, 30-minute lockout time. Other alternative technique, which one nowadays I use a lot, is a superior trunk block. It is also a phrenic sparing alternative interscalene block, phrenic sparing regional analgesia for shoulder surgery. Recently, last year, a group of them was describing the catheter technique for the superior trunk block. In their description, they will give a 10 ml bolus of 0.2% ropivacaine, and post-operatively, they will run the infusion at the rate of 5 ml per hour. This is some of my patients who underwent the shoulder rotator cuff repair in my centers. My routine is usually single shot interscalene block or maybe superior trunk block. All depends on the patient's external anatomy, any risk of getting the frenulum palsy. My bolus volume usually is just a 15 ml of level vacuum 0.3%. But one thing is that I think at the end of the surgery, my surgeon will give an intra-articular marking adrenaline diluted because to reduce the bleeding with perioperative multimodal analgesia. Most patients able to do physio quite pain-free throughout the whole duration of stay. I did the same for this patient who had a septic arthritis in the left shoulder. He went through a first surgery, which actually, with a single shot interscalene is enough. But because 3 months later, he has to go for the major rotator cuff repair plus the arthrofibrosis of the granulofemoral joint, I put in a catheter for him, and I run connected to the portable pump with the multimodal analgesia. With this, I want to show you a quick video using this. Yeah, patient able to do all the passive range of movement. What is my strategy? I know that patient has this single shot catheter. You just have a look. You see, total amount of usage is only 6. Yeah. Okay, I need to stop here for a while. Back to the same patient. What I wanted to say is that, you see, in this case, what I did is that patient already received bolus first, and also surgeon will have given some local infiltration analgesia intra-articular at the end of surgery. So I know that this patient will have a good duration of analgesia block post-operatively. So I use this pump without background infusion, but just for the boluses for the patient prior to physio or after physio. So eventually, for this short duration of less than 2 days of stay in the hospital, after surgery, he only used 6 times. Total volume use is only 12.5 12 mil. Ropivacaine 0.2, but each time bolus is 2 mil. Yeah, and patient is pain-free throughout the whole surgery, perioperative until discharge, together with multimodal analgesia. So I move on to another surgery, which is a total knee arthroplasty, the use of continuous femoral nerve block or continuous adductor canal block. In this one, I really want to take opportunity to highlight this article, Regional Anesthesia Roundtable by international expert, published in 2018 Anesthesiologists News. You see, these expert panels are 7 of them. They are head of regional service in their own respective big regional center. And in one of the segments, they shared about institutional perioperative analgesia prescription for 7 painful, more than 8 painful surgeries. We have a look at the total knee replacement. Yes, in some centers, adductor canal block catheter and femoral nerve block catheter are done. And what are the common infusion rate they do? Ropivacaine 0.2%, about 4 ml per hour for 3 days. Some are using 5 ml per hour. Yes, some do not mention about their regime. These are what done by them in the big centers. What about in Toronto Western Hospital, in which the Professor Vincent Chan, Richard Brew, Anahi Pelas, KJ Ching base, they have moved on from continuous femoral nerve block technique to single shot adductor canal with local infusion anesthesia with spinal intra-articular morphine. Previously, this happened after 2014. And if you can look at the infusion rate, they usually use ropivacaine 0.2%, 5 ml per hour, bolus 5 ml, local time 30 minutes for 48 hours. For this is interesting because Dr. Edsel Morris, he is from Marseille. He's sharing how he used the continuous femoral nerve block for their patient discharged very early as outpatient, and their regime is 0.2%, ropivacaine, basal rate is 2 ml per hour, bolus 2 ml, lockout period 15 minutes. What is interesting here is that in their centers, they do annually about 5,000 over catheters, and they have patients, they can have remote monitoring using the portable pump as mentioned, and to adjust the rate and to see what is the progress of the patient. Adapted cranial catheter, as mentioned, this is one of the latest articles pertaining the. For those of you who would like to do adapted cranial catheter, what are the common regime that is used in infusion regime? Some using the 20 ml, 0.5% bolus. Then post-operatively, they run about roughly 0.2%, 5 ml per hour, 8 ml per hour. Because adapted cranial is a compartment, I would prefer to run on a higher volume. Okay. So in my clinical practice, yes, all these picture collages are my patients that I done in private practice. And the last time I inserted a catheter is for a patient who has a limited analgesic choice because patient is allergic to paracetamol and NSAIDs, which is very important for the rehab of this thing, post-op patient. And so if catheter is still a technique of choice if my patients have limited analgesic options post-operatively, and patient belongs to the very low pain threshold group. So you put a catheter, definitely yes. But most of the time, most of my patients with a single shot follow whatever the Toronto Western Hospital regime. My patients are usually mobilizing by the next day, and most of the time they discharge post of day 2. And also depend on which surgeons that I do with. Okay, I do have patients who discharge immediately post of day 1. Actually, in Malaysia, I said most of our patients are less educated. They don't know how to monitor at home. So we are towards the peri-operative ambulatory home surgical home or ambulatory continuous peripheral nerve block is still far milestone for us to achieve in Malaysia. What about hip fracture for continuous fascia iliaca block? It is evident that the regional block is essential. It should be integrated in the routine pain management pre-operatively. And in the Malaysia context, it is very important because in Malaysia, a lot of our patients who are elderly had a hip fracture, they cannot be fixed. They don't undergo surgical fixation as early as what is recommended by the hip fracture pathway, which is actually hip fracture supposed to be fixed within 24 for 48 hours. A lot of us in Malaysia, the patients, they come to hospital late, and the hospitals are constrained with other surgeries. But if if the patient comes to hospital and surgical surgical day is not ready, fascia iliaca continuous block actually is a safe and effective analgesic modality. This is also shared by our Singaporean group just published in the last year, John Tay and his team. And these are the systematic review of the fascia iliaca compartment block. These are common infusion rate that, as you can see, shared by the authors. Ropivacaine infusion rate, the key is actually this is also a compartment. You should give a volume effect. That means high bolus. Then after that, you run at there's no studies showing the PIB. Usually now we run as an infusion for FICB. These are some of the patients that we have to put in catheter because surgical patient is not medically optimized for the surgery, but indeed it helped with their pain control prior to surgical fixation. Continuous thoracic paravertebral block is already an established technique. It's widely used for various kind of surgeries as mentioned in this table. But I refer to this article by Prof. Kamaka, an old article 2001. This is the table of drug dosage for the thoracic paravertebral block. For adults, usually we use ropivacaine, lidocaine, infusion rate 0.1 ml per kg per hour. But I said in the article, there are no published data that describe an optimal dose or concentration LA for either single shot or continuous thoracic paravertebral infusion. ESP, yes, is now gaining popular. I thought actually earlier speaker will speak a bit about ESP, but because of that, I don't really prepare much. But as you see, even though ESP was introduced in 2016, by 2019, there are a lot of articles, 125 articles describing this use. And this is just a table of ESP block used for in RCTs in various surgery, like breast surgery, cardiac surgery. Professor Marquet, yeah, his team with our Vietnamese team, there are a lot of you here today. Yes, you are using it for the cardiac surgery. And this is the sharing of from his slides there. What are the induction ropivacaine doses and the analgesic post-op doses? And yeah, the team promote the use of PIB. That means 6 ml 6 hours bolus. Yeah. Breast surgery, as shown in this slide, you see there is a use of continuous peripheral nerve block like either thoracic paravertebral or ESP catheter for major breast surgery like recon. In UM, when I was there, we started a pilot project. Now it's still ongoing. It's ongoing, but a bit affected by COVID crisis. What we did is that we put an ESP block catheter part of ERAS program, and we realized that with the regimes that we give, most of the time the patient has minimal post-op pain, and patient discharged within 48 by second day post-op. And this is how all the patients happy faces that we have. These are the regime that you see. We're using a micro pump because it's like a portable. So we give a background infusion rate of 5 ml per hour. PIB, programmed intermittent bolus, every 6 hours, 8 ml. Patient can press of 5 ml if required. But most of the time, as shown in this chart at the end of the day, they hardly press using the PCA, only 2 times. And by using this ESP catheter for 16 hours, overall volume of the reservoir is 200 plus. You haven't finished, but patient already allowed to be discharged. Rib fractures, another painful condition that there is a new update on the regional anesthesia techniques for rib fractures. As seen in these crowded slides, you can see that there are various regional techniques can be used. It all depends on the site of the fractures. As mentioned here, you can use either thoracic paravertebral, ESP, or serratus anterior catheter technique. This is our group did studies and published as a case report in the letter in the Indian Journal of Anesthesia. These are 4 morbidly obese patients with traumatic rib fractures require respiratory support in ICU and receive the ESP catheter. Mind you, all these patients with the median BMI of 35.2. So thoracic paravertebral is ideal, but for this patient, it is technically challenging and difficult with the poor sonor anatomy. And our regime for this patient is a continuous ESP 8 ml per hour bolus, manually infused bolus by the nurses in charge 10 ml every 12 hours. And we do admit that with MIB or PIB, patient feels better analgesia compared to the background infusion. This is a good diagram to show you. Before the patient received ESP, the BP was extremely high. It's in the stress. But after immediate half an hour after the ESP bolus was given, BP improved. All right. Move on to, yes, you may be talking that now I have moved to private, I may not do so much block. Yes, it's true. But this is one of my recent last month, I have a patient that indicated he has severe pain, can't do as physio. Yeah, with the ESP catheter that was done, patient really, as you can see, she was really happy, in a happy face. So what about midline laparotomy? There is a growing trend and also to use a rectal sheath block. When the first presenter, second presenter was still talking about their presentation, I see that there are a lot of inquiry about rectal sheath block. Thankfully, I put out all this information. As mentioned in this BEGA education, rectal sheath catheter analgesia for patients undergoing laparotomy. Rectal sheath block catheter is now used a lot in Australia and UK. For these authors institution, how they give 20 bolus 20 ml ropivacaine 0.2% to both catheters 6 hourly. Alternative, they use manual bolus given by the staff, 20 ml bupivacaine or level bupivacaine 6 hourly to each catheter. Yes, some of them use a Y catheter connector, but as I said, it all depends on the availability in your institution. These are the regimes. I also want to highlight a recent webinar just by Astra, rectal sheath catheter post-op for midline laparotomy. The 2 speakers, like Dr. Anton Krish, he is actually the author for the textbook Analgesia in Major Abdominal Surgery. In his institution, they use a lot of rectal sheath catheter. This is one of their patients, post-op day 1, already walking with rectal shift catheter and just underwent a major colorectal surgery with a stoma. So Dr. Narayanan, another speaker in the East Extra, he summarized their practice in their institution in Frimley Park Hospital. For elective laparotomy surgery, they will give a spinal analgesia with intrathecal morphine, and post-op, they will put a rectal shift catheters and let patient to use a PCRA. But for emergency laparotomy, post-op, they put a rectal shift catheter infusion and PCA for patient to handle the breakthrough pain. If patient is allowed orally, they will provide PCRA for the rectal shift catheter and oral opioid as a breakthrough pain. Well, there are a lot of blocks in the new blocks in the blocks. I mean, in like quadratus lumborum, all these things. But most of the evidence are still confined to case series. So due to the interest of time, I cannot put everything here. But the summary of my slides here is that there is a changing trend of using continuous peripheral nerve block. Truncal analgesia like ESP, RSP are gaining popularity. The optimal infusion, whether it still remain unknown. But infusion pumps, we know that electronic pumps will provide a more stable basal infusion rate. Portable lightweight pump is really ideal for the position post-op required early mobilization, in line with our concept of now the enhanced recovery after surgery. Thank you for listening to my talk. Thank you.
Okay, thank you, Dr. Beh. Excellent talk. So many information.